Welcome everyone to session 7 in the Oxygen Therapy and Critical Care case-based series. Today's topic is defining ARDS, and as usual, we are graced with the presentation by Dr. Eugene Tuyishime and his panelists, Dr. Jean-Paul, Dr. Celestin, and Dr. Alain. With that, I'll just hand it over to Dr. Eugene. And just before we begin, a quick note that if you have any technical difficulties throughout the presentation, feel free to put a note in the chat and we can assist you.
Yeah, thank you very much, Alana. So today we're going to discuss about ARDS, and I think it's a very relevant topic for all of us. So I will let maybe Alain make a small comment, and then we'll start once you share the content. Thank you.
Thank you so much, Dr. Eugene. So I'm happy to be back with you. So I was out for a while, but it's always a pleasure to discuss such issues that we face in our daily activities. Our ICUs are full of sick patients, and I think, according to what I see, more than 70% develop this issue of acute respiratory distress syndrome. So partly this is a good topic, and I hope that everyone will enjoy it and will help to do great things before that we see those patients coming on our side, because early intervention is the best thing to solve such issues.
Very good, thank you. So maybe Jean-Paul will join when he comes, and Celestin. So let's start with the objectives for today. So the objective for today, we need to be able to define respiratory failure, to list the types of respiratory failure, define hypoxemia using a pulse oximetry, define hypoxemia using arterial blood gas, list the 4 key criteria for ARDS definition. We'll be able to apply the Kigali modification of diagnosis of ARDS. We'll describe mild, moderate, and severe ARDS. We'll discuss briefly about the pathophysiology, and then we'll discuss about the principles for lung protective ventilation. We need to understand the basic about the parameters and the mechanical ventilation. And then we'll discuss about also CO2 elimination while we do like mechanical ventilation. And then we'll discuss some appropriate intervention which may improve oxygenation, and then some of interventions which have shown to improve outcomes. So those are the objectives. So remember, this is an interactive session, so you can jump in anytime, you can write in the chat, we'll be able to answer your questions. I think you can start with the case. So you remember our previous patient who was very sick. Now the patient is in ICU. So Mr. T is a 46-year-old man who presented with hypoxemia and respiratory distress. Unfortunately, he was found to be positive for COVID-19, and his clinical course progressed to respiratory failure, requiring ICU admission, intubation, and mechanical ventilation. His vital signs and the mechanical ventilation settings are as follows. As you can see, the heart rate is a little bit increased at 102. The blood pressure is 97/51. The respiratory rate is 35. The temperature is 37.5 degrees Celsius, and SpO2 is low at 90%. The patient is on volume control, FiO2 of 100%. The respiratory rate is 35. Tidal volume is 400, and the PEEP is 14. And the pressure is 40, which is very high. So let's remember this case as we discuss about respiratory physiology and respiratory failure. Let us start with a very basic question. why do we breathe? People can just write in the chat their answer. What's the goal of breathing? You have like 30 seconds to answer that, and then we'll watch this video and we'll continue. Okay, I see a few of the answers. Nice. Gas exchange, that's very broad. So who may be more specific? Okay, Adan Hussein, we discussed that, why the pressure is 40. It's not PEEP, that's the pressure of it's pressure of inspired pressure. Peak
inspiratory pressure.
It's peak inspiratory pressure. So it's not what we said, it's what was happening to the patient. So the PEEP was 14. Thank you, Aaron. Oh, here, okay, here is a very good answer, I think, in a summary from Infinix Hot 10. I don't know the exact name. So we breathe to get oxygen in and get out CO2. Okay, I think that's reasonable. Ari, what do you think?
So all the response, but this is a good answer, but maybe we push up and know why this oxygen and why, what does it help in our body? Maybe this is so important also to understand. Is it enough to have oxygen, or do we need other things to be combined to oxygen to get what we need as energy? And maybe I think we progress with that.
Yeah, that's a good discussion. I think we don't have that on the video, but we will share the content for the details. But as you said, just in summary, we need like cellular oxygenation and aerobic metabolism in order to have enough energy, where there will be glycolysis, where we'll have like glucose produced and ATPs produced through a cycle of like advanced processes. So let's watch the video.
When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea divides into two bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale.
Okay, thank you very much. I think that's a good summary. Okay, let's continue with respiratory failure. So, and people can just choose the right answer here. Which one of the following statements about respiratory failure is incorrect? Choose one among those 5. You have about 30 seconds. Thank you. Okay, we can continue. The correct answer is D. As you know, respiratory failure doesn't resolve by itself, so you will need to treat that. But others are correct. Respiratory failure is a failure of gas exchange, either oxygenation or carbon dioxide elimination. Respiratory failure can be acute or chronic. Respiratory failure is a syndrome rather than disease, and patients in respiratory failure may have tachypnea, hypoxemia, and hypercapnia. So the wrong answer is, the correct answer is that respiratory failure usually resolves on its own. That's not correct. Okay, let's also discuss the types of respiratory failure. People can just write in the chat a list of the respiratory failure they know before we go in details with ARDS in the following slides. But remember, we are still in introduction before we go in deep in the topic, and then Ale will help us during that discussion.
I think, Eugene, for the previous question, you may need to give some details why A was correct, or what do you think?
Yeah, if you need to give more details, you can go ahead. But I think we will get more understanding as we discuss through the topic.
Okay. Like respiratory, the reason why, like A is correct, that included on the next question, I think.
Exactly, yeah, that's what I was saying. As we continue to discuss, we'll be able to answer most of the questions there. See what people responded. Yeah, just to guide our responses. Remember, you said that oxygenation include like entry of oxygen and also removal of CO2. If you even start with that, you can be able to find some types of respiratory failure. And there is a good article on the link. Maybe after the course we'll share that. After the discussion, you can see all the details. Because I see people are very quiet in responding. Okay, let's click on the link on the reference, and then we'll see a good explanation of this question. Yeah, you can stop there. Let's start with the definition. Alana, can you go a little bit up? Yeah, here. So as you can see, acute respiratory failure is defined as a loss of the ability to ventilate adequately or to provide sufficient oxygen to the blood and the systemic organs. The pulmonary system is no longer able to meet the metabolic demands of the body with respect to oxygenation of the blood and CO2 elimination. So they classified the respiratory failure in 4 types. Type 1 is hypoxemic respiratory failure, where the PO2 is below 50. They give few examples, including pulmonary edema and acute lung injury. There is a problem of the ability to oxygenate blood once the blood is passing through the pulmonary vasculature. So the type 2 is hypercapnic, respiratory failure, and CO2 is increased. So there is difficulty in removing CO2, and you can imagine about all the things which can affect the brain or also the chest, so which will decrease the capacity to remove CO2. Especially in our work, we give too much anesthetics, including opioid, for example, or muscle relaxant. Those are a few examples. Then people with neuromuscular diseases. Okay, and then we have like a perioperative type, which is a subtype of type 1, because most of the people will have hypoxemia either from atelectasis or things like that. And then type 4 is shock. And as I think Alain knows and Jean-Paul, we see a lot of people with shock, interceptic shock, cardiogenic shock, and the hypovolemic shock. So that also may cause hypoxemia because there will be no delivery of oxygen to the body. So I think there is a good examples if you go down to this paper. We can go through, but we will not go in detail because you will have the access to this document. And in addition to that,
And actually, I'm so happy to see such examples because we live with that. And I was at the beginning, remember, I was saying that some of the issue we met in our clinical practice can be tackled at the base or at the basis. Maybe the example would be type 4 shock. The shock, if the shock is treated early, maybe once the patient arrives on our settings, we can get good outcome. That's why I've said that with this presentation, we get a good opportunity to discuss with the whole team to see what we can do to get or to solve some issues which affect our practice once we have such patient. Also, the type 3 of how we ventilate our patient in our theaters also is a key word. How to give enough fluid, not too much. Those discussion, I think we get good discussion on that.
Yeah, Arana, before we move, can you go down on etiologies? Because people can just have a look and that's very fast. So as you can see, there are multiple causes, like the drugs we give, infection, people with meningitis, for example, or cerebral malaria, they can have hypoventilation. People with spinal cord injury, we see those patients. People with neuromuscular diseases like tetanus, sometimes we see those patients sent to our settings. Guillain-Barré syndrome is common. Obesity, upper airway obstruction, people with infection, tracheomalacia and children, bronchospasm. These are common examples. And then you can go down to hypoxamic respiratory failure. I think this is a common teaching. We can't go in detail about this. Just remember that FIQ mismatch is very common and trans. We can go down as well. Yeah, as Aaron said, cardiogenic pulmonary edema, ARDS, pneumonia, lung hemorrhage, especially in trauma, atelectasis. Yeah, you can go down a little bit. I need to see the perioperative issues as well. Yeah, you can continue, go down. Yeah, here. So as you can see, there are many things which can cause atelectasis with decreased FRC, patient in supine position, obesity, ascites, our anesthesia. So we need to make sure there is no residual anesthesia, no residual muscle relaxant, no overdose of opioid. And remember, when you have like people with laparotomies, with upper abdominal incisions. Those people may have a lot of pain and develop atelectasis, a lot of airway secretions. Yeah, I think those are the things to think about. So thank you, Aaron. We can go back to the main slides. So that will come with the question to everyone. So what type of respiratory failure do you think our patient has? You can write that in the chat. We have seen 4 types. So what do you think our patient has? Is it hypoxemic? Is it hypoventilation? Is it perioperative? Is it shock? You can just pick one. Okay, yeah. Eugene is saying hypoxemic respiratory failure. Daniel, okay, that's very good. Yeah, type 1, okay. Yeah, I think most of the people got the correct answer. So our patient has hypoxemic respiratory failure. So let's continue and see how we can approach that. And as we discuss about ARDS. So this is the current vital signs for our patient. As you can see, despite FiO2 of 100%, the saturation is down at 288%, and CO2 is 31, and the respiratory rate is 32, which is also tachypnea. Can go down. So I think we'll not spend a lot of time discussing about hypoxemia definition of pulse oximetry. At least people can write in the chat at which saturation will you decide that someone has hypoxemia? Is it 95%, 88, 90? Just put a number and then we can proceed to hypoxemia with ABG. Yeah, again, the question, the first question is, how would you define hypoxemia using a pulse oximetry? It's a very simple question. Okay, Crowd is saying that SpO2 below 94, MA below 90%. So we'll go with 90%. If someone has a SpO2 below 90%, then they are hypoxemic. And what about ABG? On ABG, which number will be the cutoff to decide that someone has hypoxemia? You can put that number in the chat. So while they are answering that, I think I got a chance to go around the country. Do we have ABG in district hospitals or we don't? Even the laboratory?
No, we don't have arterial blood gas available in many places. I think I've seen them in Kigali. Kigali, we do have in our 4 main hospitals, but it's not always available. We can miss some samples or we need some, but in district hospitals, I didn't find anywhere. I'm not sure. Enough, even in big provincial hospitals, they don't have.
Okay, so even the laboratory, they can't give you like any value, like PaO2, you can't get that number. Okay.
So the PaO2 in laboratories, I'm not sure, but think about the time it will take to take the sample to go to the laboratory. I think we don't have this in district hospitals.
Okay, yeah, thank you. When I was in the Greenhouse Hospital, we used to have few machines, but there was a problem to have like the cartridge, things like that. Then they stopped working. So let's see the answers about ABG. We'll just discuss about that briefly, just as a reminder, because we don't have it available to us. I see that the donor is saying that the cutoff is 60 millimeter of mercury. So we can just click on the reference. I think that's a good cutoff. Let's see what is available in our reference. I keep going down. Yeah, that's good. You can go up a little bit. Yeah, that's it. So you can see the critical values, the normal values of ABG. So the pH is usually between 7.35 to 7.45. The PaO2, that's what we were asking, is usually for this, they are saying between 75 to 100, but there are some references where it is 60 to 100. I don't know if that's correct.
Yeah, because if you try to link the PaO2 of 60, it will almost equal to a saturation of 90. So that's why many people take it as a cutoff.
Yeah, perfect. So the CO2 is between 35 and 45. So bicarb between 22 and 26. So base excess between -4 and +2. Saturation 95 to 100. So this is just an idea. We don't have to go in the details because this is not the main topic for the day. That was just an introduction before we discuss our main topic, which is ARDS. So I will open a discussion for this general introduction. People can ask questions in the chat, and all co-panelists can really jump in and give any addition before we discuss about ARDS. So while we're waiting for questions, Celestine, Jean-Paul, Alain, feel free to add anything.
Thank you, Eugene. What I want to add is about this type of respiratory failure. So that you have like 4 types. Just the main one is hypoxemic and hypercapnic. So to make it easy and understandable, hypoxic, it's a matter of lack of oxygen, either in the tissue, either in the blood. Hypoxia in the tissue, hypoxemia in the blood. When a patient is not having much oxygen in any way, a patient is not getting much oxygen, he will become hypoxic, hypoxemic. That's one. For hypercapnic, it's high CO2. A patient is not able to eliminate the CO2, and the CO2 is accumulated into the lungs. The moment a patient will become hypercapnic, any condition which decrease respiratory rate, which lead to apnea, a patient will be keeping accumulating CO2. This is what I want to comment or to clarify a little bit, to make it a little bit understandable and easier. Hypoxemic, it's a matter of oxygen. Hypercapnic, it's a matter of CO2 which is not being eliminated adequately. And the second comment was about this hypoxemia and the ABGs, blood gas, arterial blood gas analysis. So as my colleague Are mentioned, ABG is not widely available in this setting. It's available at King Faisal, sometime at military hospital, sometime at Sashika. Here at Sashibe, we don't have. But even if you don't have an ABG, you can think with SpO2, as Are mentioned. If a patient is desaturating or is oxygen saturation is less than 90%, you can estimate partial pressure of oxygen in the blood, which is less than normal one, which is 60. Even if you are not quite sure, you don't know how much it is, but if a patient is desaturating less than 90, it gives you an idea that whatever it is, partial pressure of oxygen in the arteries is less than 60, which is not normal. For those who will be interested, they can read oxygen dissociation curve with P50, just to have an estimation of arterial. It's a little bit, but if you want, you can read about it. You can see this estimation in a setting where I don't have an ABG. This is my comment.
Thank you, Jean-Paul. Any addition from Are or Celestine, and then we can move on to ARDS?
I think I was waiting, Celeste. Maybe he was trying to unmute himself, but I think let's once we move on ARDS, many comments will come how to adjust issues according to our means. So maybe I should not jump on it, but with progress with this presentation, we should see how to adapt ourselves with our conditions, especially with the lack of some materials like arterial blood gas machine, how we can come up with some solutions.
Thank you. Celestine, any addition? Okay, so I saw that people have answered the question about ARDS, and everyone was correct. So it's acute respiratory distress syndrome. So someone who said adult, that was before, but ARDS can be a problem for even children. That's why it changed its name to acute respiratory distress syndrome. So we can see the definition for ARDS. Yeah, go down. So this question is asking about the 4 component in the Berlin definition of ARDS. I'm not sure if people are familiar with that. We can give you a few seconds to write in the chat if you are familiar about the component of the Berlin definition for ARDS. Otherwise, we'll go to the link and then we'll discuss about that. We'll give you 30 seconds. Okay, Bernard, that's a good trial. Okay, we're going details, timing of oxygenation and PEEP. Chest imaging, yeah, chest imaging is part of it. But is it a CT scan? Is it a chest X-ray? And what do you find on chest X-ray or CT scan? Okay, so let's click on the reference because I think most of the people are not very familiar with ARDS, which is good. We're going to discuss that. So there are 4 criteria, as you see. First, to have a respiratory insult within 7 days. You can go up. Okay, continue down a little bit. Continue to go down. Okay, continue. So I think the definition starts with the content. The definition of ARDS starts on the top, I think. Okay, go down. Yeah, go down a little bit. I can't say that, but we can use. I don't know. Am I allowed to share my screen?
Yep, yeah, definitely. You can share.
Okay, yeah, let's share my screen. Okay. I don't know if everyone is seeing my screen.
Yes, we can see.
Yeah, so the Berlin definition of ARDS has 4 criteria. As I said, you have to have respiratory symptoms within 1 week of known clinical insult. In my experience, I have seen people with pneumonia or people with chest trauma or other respiratory infections. And then you have to have bilateral opacities, which must be present on a chest X-ray or a CT scan. So these opacities must not be fully explained by pleural effusion, local collapse, lung collapse, or pulmonary nodules. So in other words, these opacities should be related to the primary chest insult. And then the patient respiratory failure must not be fully explained by cardiac failure or fluid overload. So that's why you need heart ultrasound. And to exclude hydrostatic pulmonary edema. So, and then you have to have a moderate to severe impairment in oxygenation as defined by arterial oxygen tension as a fraction of PaO2 over FiO2. So PaO2, you get the number for arterial blood gas, and FiO2 is the amount of oxygen you are providing to the patient. And you may define the severity from mild to severe according to the PaO2 to FiO2 ratio. So if the ratio is high, then you have mild. And if the ratio is very low, you have a severe ARDS. So it means that you are needing a lot of FiO2 in order to achieve a PaO2. But also remember to have a PEEP of 5 centimeter of water. So mild is the PaO2 to FiO2 ratio between 200 and 300, and moderate is between 100 and 200, and the severe is below 100. So that's in general. So I will rate.
Maybe a small, just a way of understanding this and remembering it. I've seen some comment of one of participants talking about timing. So once he was talking about timing, it was about the onset, the first condition to get ARDS. So you when talk about timing, it's about time, and it is within 1 week. And once we go to those bilateral opacity, there we think about imaging, chest imaging, either radiography or CT scan done. So once, this is the second way. So you think about timing, then you think about chest imaging, then we've talked about respiratory failure, which is not fully explained by cardiac failure or fluid overload. There you've introduced this idea of doing, of course, an ultrasound. So there we think about the origin of this edema. So, and the last one will be interpreting the result of ABG in comparison of the FiO2 which is given. So the first condition is about timing, the second one about chest imaging, the third one the origin of edema, and the fourth one is to combine the result of ABG with the FiO2 which is given. So there you can even remember it for a long time.
Thank you very much, Alain. So yeah, and remember in our context, we may not have a CT scan in most of the hospitals, and then that's why the authors from Rwanda, including Dr. Eugene, so they defined the Kigali modification. So that's what we'll see next, because they replaced the CT scan by ultrasound, and then also they replaced the PaO2 by saturation of oxygen with pulse oximetry. And then they calculated the according numbers of oxygenation we need. The PaO2, the SaO2 to FiO2 ratio we need to define the ARDS, but also they removed the PEEP because sometimes those patients are not on a ventilator. So I think those are some of the modifications they did, and maybe Are will help us to understand more. I was just saying that. Alana, we can go back to the main slides and see the Kigali modification, because I think that's applicable to most of our hospitals. Okay, yeah, so maybe before we do that, we can ask people to try to calculate the PaO2 to FiO2 ratio to see if they understood how it is done, and then we can continue.
And it will help us also to know where to classify if it is a mild, moderate, or severe.
Yeah, so the question is very simple. So our patient has a partial pressure of oxygen of 60, and the mechanical ventilation is delivering a FiO2 of 80%. So what is the P to F ratio? So in other words, you have to have like the partial pressure of oxygen of 60, you divide by 80% in decimals, so 0.8. So you can calculate that and give us a number in the chat. And then after that, you have to tell us, is it a mild? Is it a moderate? Is it a severe ARDS? So your answer should be maybe the P to F ratio is maybe 200, for example, and this is a moderate ARDS, or is 80, for example, this is a severe ARDS. So you can answer like that, and then we'll move to the next slide. And I understand this is a difficult concept for people who are seeing it for the first time, but this may help really seeing the patient on time and referring the patient before they become very sick. Okay, yeah, Dieudonné got a good answer, 75. So Dieudonné, is the patient in mild, moderate, or severe ARDS? Okay, people are very quiet, but I think the donate and also the one using Techno Spark 4, they got the correct answer. So the next question is to classify the patient. Is it a mild or okay, severe? Thank you, Bernard. So I think most of the people got an idea on how to do that. So this patient is in a severe ARDS. And the more severe the patient is, the most likely they will have poor outcomes. So let's continue down to the next slide. Yeah, and the question is, can ARDS be diagnosed when ABG is not available? So as we discussed, there's a Kigali modification for that. We can click on the reference and Are will help us to discuss that. Alana, can you click on the link?
Thank you so much. So this study has been conducted. I think it's not yet shared, but maybe yeah. Thank you. So this study was done in Rwanda with maybe we can find some authors already known in our country like Prof. Eugene, Dr. Eugene, Dr. Roberto Ribeiro, and Elizabeth. So this has been conducted in our main centers where they've tried, as we already know, we have issues of getting such machine of arterial blood gas available. But we have been seeing some patients in our settings, either in ICUs or in a regular ward, who are presenting signs which were making us think about that they were having criteria of ARDS, but we're missing this component of partial pressure of oxygen, and it was causing issue to define it and to put them in that context. And if we go through it, but we found that it was possible to have an ultrasound, a portable ultrasound, which should move around and do regular assessment of patients, seeing the status of their lungs, if they have a sign of fluid overload, like we can see B lines, something like that. Technical way of using ultrasound to to see patients with issue where it comes to breathing, maybe lungs with fluid overload. So they come up with some criteria which helped us to get this Kigali modification, and maybe we're going to arrive on that. So if we compare, as we said before, what they got as a result. So remember, they're using component materials which can be availed everywhere, and ultrasound can be availed in many centers. We can get a pulse oximeter in many centers. So they were trying to focus on what we can get easily. So if we compare Berlin's criteria and Kigali modification criteria, we see them in both four components. About timing, no special thing changes. We are still thinking about that the onset should be within 1 week of a non-clinical insult or new worsening respiratory symptoms. So it is within 1 week. So when it came to oxygenation, remember that we say that people with issue of breathing should have a PaO2 or FiO2, which should be below 300. And now remember we have been differentiating between mild, moderate to severe. So once we know that we don't have a partial pressure of oxygen because we can't get an ABG machine available everywhere, they try to compare using saturometer, NSPO2. I think we have this everywhere, even in health centers. So now we can use PaO2 by FiO2, which is below 300. Then they introduced the idea of using SPO2 over FiO2, which is below or equal to 315. So this is the first modification they brought in following that study. And remember, all patients we've been using for Berlin's criteria were putting peak positive and expiratory pressure of 5, at least 5. And this was requiring an invasive mechanical ventilation. But some patients have been found in the study that some people were having sign of ARDS, and many of them were not ventilated. So we are no longer requiring the PEEP. There's no requirement of PEEP once we are talking about Kigali modification. So this is the second changes. We introduced the SPO2. Now there's no PEEP requirement. So about the chest imaging, remember, it's still almost the same. We've been talking about the opacities, which are not fully explained by pleural effusion, lobar or lung collapse. And there, the big issue was about using CT scan to get such images. But as we don't have many CT scan machine in the countries, I think we don't have more than 8. So now the idea of using a portable ultrasound and chest radiography to detect such issues has been introduced and gave a good result in the Kigali modification criteria for ARDS. And about the origin of edema, we are still thinking about respiratory failure not fully explained by the fluid overload. And the best thing with Kigali criteria, we are able now to use ultrasound, and nowadays that's what we do in our daily activities. Just you put the right probe on the chest and you can see what you call B lines. If they are there, you can think about that someone has fluid overload. So in summary, if we go back, about timing, we are still in the same, they are still the same. About oxygenation, the idea of SPO2 has been introduced because we're lacking machine for PaO2. We are no longer in Kigali modification criteria using PEEP because some person or patient were not ventilated. So this PEEP positive and expiratory pressure was not a exclusive criteria. So about chest imaging, in balance criteria, many of the cases were followed using chest radiography or CT, but now in Kigali modification, the idea of ultrasound has been introduced with success. And about the origin of edema, we are still thinking about a respiratory failure which is not explained by cardiac failure or fluid overload. And as I said, the ultrasound now is so helpful to identify such issues. Maybe something else to add, yeah?
So for me, what I can just add is that for people who are getting this topic for the first time, so we don't need to memorize these criteria. They come with experience as you use them, and as long as you know the Berlin criteria, the Kigali modification, you can even look them up. So either on internet, up to date, things like that. As long as you have the principle and you know that those criteria exist. Second point is that if the patient is hypoxemic, meaning the saturation is below 90 and the FiO2 is very high, above 60%, so you need to start thinking about ARDS right away and then plan to send those patients in the centers with like ICU capacity. I think that will be a good take-home message for me if I was working in a district hospital. So I don't know if people have any addition before we proceed. If there are questions, you can put the questions in the chat, and Jean-Paul and Celestine, you are welcome to make few comments before we continue.
As you said, the most important thing is that people should understand that we can still diagnose RDS in limited resources. When you compare to Berle definition, that's even why they brought Kigali modification. So in our limited resources, for what we have, for what is available in our setting, we can still have an idea of knowing that a patient is in RDS situation. Mainly, like the timing, which was not changed. If a patient came with suspected respiratory insult within a period of 1 week, so you can still have a clear idea that this patient might be in RDS. For the other one of modification, where we don't have an ABG, in each hospital we have pulse oximetry, and we have also the oxygen flow. The you can know what is FiO2 are you giving it to a patient. If you are giving nasoplunge and you know what is FiO2 a nasoplunge can give, and you have also oxygen saturation of a patient, you can still calculate this one, oxygenation. If you are a patient is on facial mask and you know the facial mask, the maximum FiO2 a facial mask can give. Remember on the previous session we saw before, and you compare to the SpO2 the patient is having, again you can have this idea of oxygenation. So I'm proudly about Kigali modification because these are the things we have in our setting to have an idea that a patient is in RDS or not.
Thank you very much, Jean-Paul. So yeah, we can maybe do a quick review of the pathophysiology. I don't know if you see my screen, but on A is showing a normal alveolus. So as you can see, there is a good, it's large, and you can have, there's a good air space, as you can see here. But in the left, you can see when there is a start of ARDS. So you have exudation phase, where you have a lot of fluid, and you have a lot of inflammatory cells coming in. so which is a big problem in oxygenation. So there is damage to the endothelium and the epithelial cells, and there is no, the surfactant is decreased. There will be a collapse of alveolus, and then there will be issues with oxygenation, as you can imagine, because the alveolar air space will be decreased. So this is the first phase. So it's the exudative phase or exudation, what means that there's a lot of permeability and a lot of fluid coming in, inflammatory cells, including neutrophils. And then after that, you have a decrease in the alveolar air space, as you can see. So the air space is decreased. Here it was full. So then the second phase, after a few weeks or a few days, there will be a proliferative phase. It's like a little bit of healing. As you can see, the alveolar air space is getting better and bigger. So the inflammation is decreasing and the surfactant is again well produced, and then you can have better oxygenation. But in a small percentage of patients, there will be a third phase. So the third phase, as you can see here, it's fibrosis. So there will be a lot of collagen deposition, and then there will be fibrosis. But we don't need to memorize that, just we need to see the difference. So initially exudation, a lot of inflammatory fluid, and then proliferative phase where inflammatory fluid is decreased and the air space is better, and then there will be, for few people, fibrosis and long-term damage, where you have, again, a decrease in the air space. Those are just in general. I don't know if people have any addition to that. So then if there's no addition, we can continue to the main slide. Yeah, we can watch that video. It's a very small video showing alveolar damage. You can see how the size will be decreased with a lot of inflammation. Yeah, you can see there is a collapse of alveolar. So we can go down to the next slide. I know this is a lot of information, but there are a lot of few key points. So for the treatment, we discussed a little bit about mechanical ventilation, but because of most of our participants don't work in ICU, I don't think we need to go in a lot of details. We will do an overview. I don't know what other people think. Maybe Jean-Paul or Alain or Celestine, what do you think?
Personally, I think if there are some question, we can keep in group discussion and maybe they will ask about it, because many things which are done in ICU are more technical. So I think it's not so easy to understand them once you don't use them, but we can always explain about it.
So thank you. Let's go through very quickly, because I don't expect people to become just expert in using like ICU machines. Yeah, you can continue going down. So so here, just the key point is that really in ICU what people are doing, and I'm not the expert in this field because I'm not working in ICU, but Ari will be welcome to add. But most of the people are doing low tidal volume ventilation and high PEEP, so in general. So the other thing I have seen is that the tidal volume is not enough only because people with ARDS will have a high FRC, a low FRC, and they will be prone to a high risk of injury if you have a high PEEP, a high tidal volume. So what it means is that people will also be able to calculate the difference between the plateau pressure and the PEEP, and then be able to know the exact pressure they need to use. But those are new guidelines, and I saw there's a good reference we'll share after the discussion. So just to not, I don't need to confuse people. So the key message is low tidal volume and high PEEP. And then people with expertise in ICU will do more adjustment. I think we can keep that way for the purpose of the discussion. I don't know if people have something to add on that.
Yeah, thank you for it's really helpful to understand that, and also the FI2 should be adjusted in places where we have ABGs according to what we have. We should not aim to have 100% of FI2 once we have good PaO2 above 70 or 80. So we have to adjust always the FI2 according to what we have as a result of PaO2 on ABG. So maybe this can be discussed in small group, or we can find always a way of explaining more, because I think plateau pressure, once you don't use such machine, it's a bit difficult to understand. But the plateau pressure is the pressure once you hold the machine is sending the pressure on the patient, and it's like during the inspiratory pause, it's like it's driving through all alveoli from the big to the small one. So there are many small some technical words like peak inspiratory pressure. The meaning, maybe if there are questions, we can always explain more on that. But the peak inspiratory pressure give an idea of the resistance to the pressure from the airway to the tube till the alveoli. So it's like the peak, the highest peak you can get. So maybe you can always try to explain on that.
Yeah, I agree. For me, I think the best way is to give a general information, and then once people come, either in rotation in ICUs, or if we have like a chance to meet in person for like more training, we have like other courses with like advanced critical care courses, things like that. We can be able to go into details, because it is very hard to explain these concepts just remotely like this. So yeah, let's go to the next slide.
Eugene,
yes.
Before we jump on the next slide, I have a few comments for what you mentioned. You mentioned the low tidal volume. The majority of our audience, these are the people whom we work together in the operating room. Mostly when we are setting the tidal volume of a patient who is going to undergo an anesthesia or a surgery, most of the time we calculate 60 to 80 mL per kg of ideal body weight. I'm not sure if we are calculating ideal body weight, because we usually don't have obese patients. So,
and it's an issue to measure the weight. No, I'll say
when you say low tidal volume, at least we should understand, in this case of having a patient who is having an ARDS, this moment we are not considering 60 to 8 or even to 10 mL per kg. Low tidal volume, that means is less than 6 mL per kg. So we start from 4 to 6 mL per kg with ICU ventilator. If you have an ICU ventilator, sometimes we do use anesthesia machine for temporary reason. But low tidal volume, Eugene mentioned, was 4 to 6 mL per kg. I also commented about low FiO2. In these patients who are having ARDS, it's not better to have high FiO2. As soon as you should reduce the FiO2, because all of us, we saw in the previous session that the exposure on high FiO2 is also toxic. Oxygen is toxic. That's why these patients who are in ARDS, their lungs can't tolerate the high FiO2. Where is it possible? Sometimes like this COVID patient, it's a little bit challenging to maintain their oxygenation with low FiO2. The third one, Eugene mentioned, is high PEEP. Mostly in your operating room, we used to set the physiological PEEP, which is 4 to 5. This is the physiological one. But for ARDS patients, we even go like 10, 15, 18, the higher than you can imagine. The others, these are the driving pressure, plateau pressure, peak inspiratory pressure. But what I can comment on plateau pressure and peak inspiratory pressure, it's a little bit difficult for our audience to understand it. But peak inspiratory pressure, even you have it in the anesthesia machine. You remember when the peak inspiratory pressure increased on our anesthesia machine, we thought about obstruction, either in ETT due to secretion, mucus plug, or anything which can obstruct our ETT. It can lead to increased PIP, which is above 30. So when the plateau pressure is increased in the ICU ventilator, this gives us an idea that the problem is not about obstruction. Sometimes it's about the alveoli. The alveoli, the diffusion, things like that. This is what I can add. I understand to our audience that they might understand it very well when they come in ICU. I was just trying to relate with what they are interacting in the operating room with anesthesia machine. Thank you.
Yeah, thank you, Jean-Paul. So we have a lot of good questions in the comment. So, and I will try to answer them quickly, but we'll share some of articles with details. So Adan Hussein said, what is the best FiO2 for a person saturating at 80 to 90%? And how can I calculate or set an FiO2 for different situations? So there is no right or wrong answer, but the principles are the same. So if the patient is desaturating, as you can imagine, you go to the highest FiO2 you can get in order to achieve at least a normal saturation, which is the target above 90% in general. So without considering some specific situations like pregnant women or people with COPD, where you can have a higher setup for saturation. So a higher for pregnant and the lower for COPD patients. So, but in general, you will start high and then you will reduce the FiO2 to below 60%, because we know that if the patient is on FiO2 above 60% for more than 24 hours, there is increased risk of lung injury. So that's one. So for the other question is about the ventilator setting in a patient with ARDS. Is this different from other respiratory problems? So remember, ARDS is a syndrome. It's not one problem. So it may be caused by multiple diagnoses. So what it means is that the principle is the same. As we said, you start with raw tidal volume and high PEEP. And then there's other adjustment, including inversion ratio and other adjustments. And also you may add things like prone positioning to improve the ventilation. But the principle will be the same without considering the cause. And then according to the cause, you may readjust after. I think that's what I can answer. And I will open that to the colleagues, including Aaron. And
yeah, I'm happy that you've introduced that idea. Remember, as you said, the syndrome can be caused by a different thing. As long as you have those 4 criteria, which are maybe you think about the diagnosis and you see that it caused that, and you have those 4 criteria present. So this will be an ARDS. So once you diagnose an ARDS, be aware of what to do, how to manipulate the machine, how to ventilate the patient, how to position the patient, what to do to avoid worsening the situation, and how maybe once you are not able to do, when to, early referring to other settings, because early detection give good results.
Okay, yeah, thank you. We can go to the next slide. Yeah, so paralysis, I don't think we will discuss a lot about that, but there are some advantages and disadvantages for neuromuscular blockade. And there's a good article on the reference which you can explain that. So I don't know the practice at King Faisal if they use a neuromuscular blockade.
Yes, sometimes we do use it because sometimes once you are ventilating a patient, you have too much asynchrony. The machine is trying to ventilate, the patient is breathing, and you have this asynchrony, and the machine is going crazy. So sometimes we can give the neuromuscular blocker to allow the machine to ventilate with the patient, but we try to do our best to not to paralyze for a long time, because the objective is to remove the patient from the machine as early as possible.
Another advantage of paralysis, you remember this patient, they are having high oxygen consumption. So when a patient is paralyzed and is synchronizing with the machine, then the need of oxygen consumption is decreased. Especially we do this when you are having a patient who is very hypoxic, hypoxemic. You tried everything, especially the patient is desynchronizing with the machine. We do paralyze this patient, especially the patient who are COVID positive and present at the same time with ARDS. I've seen that the paralysis is helping much in our context.
Okay, yeah, thank you. But remember, there is no evidence on mortality outcomes. So there are some theoretical advantages, as you said, including decreased work of breathing, improved oxygenation, ventilator synchrony, decreased plateau pressures, decreased barotrauma. But there are some disadvantages, including weakness, neuromuscular weakness, and especially when you combine with steroids, you may need prolonged mechanical ventilation in the ICU stay. There's increase of risk of DVT and DVT. Allergic reaction can occur and some cardiac complications. And there is a report also on like eye injury because people they'll be paralyzed for a long period of time. Just we need to keep that in mind.
Yeah, that's a big issue. Sometimes I remember once we got an issue with the eye because, once the patient is paralyzed and is brief, he can't, the cornea, you can get some issue with the corneal abrasion. So we had some cases. So I've seen that in theater many times. We remember to protect the eyes, but sometimes ICU's patient has such issues, and we have to think about it also. It can cause issues.
Yeah, here there is a table also showing how you can prevent those issues. So people with like weakness, you may do early exercise training, and people with corneal abrasion, you may schedule eye care with lubrication, and also you cover the eyes and eyes closure. You can give also DVT prophylaxis. Yeah. So just remember that there is some potential harm.
This is pros and cons. Pros, there are some advantage. Cons, there are some disadvantage.
Yeah, very good. We can go to the next slide and discuss about fluid management. Yeah, so I don't know the current practice in Rwanda, but there are some advantages of using a conservative fluid management for the reason you can understand. If you give too much, you will increase pulmonary edema. So people will be very careful in giving fluid. But again, there are no outcomes on mortality, but there are better outcomes on oxygenation. So I don't know if someone has something to add on that.
Our approach in King Faisal, so we give fluid, but we always we don't, as you said, we don't give a deliberate free fluid to the patient. So we monitor how much we give. So as now the technology is around, we can always have an ultrasound measure how is the IVs, even if it is a direct measure, but to give you an idea of how your how much fluid you give and what is the if it is enough or not. You can also use an ultrasound to see how our lungs are. So this introduction of ultrasound, I found it so helpful in our context, as we were having some issues in the past of getting CTs or other imaging done. So this conservative approach, I find it helpful. And we have a prof who used to say that happy person, dry lungs. So it's always helpful to remember about it.
Yeah, thank you. As you know, there are some better mechanical outcomes. People will spend less time on a mechanical ventilation and less time in ICU, even if there is no change now in mortality, but those are good outcomes. Yeah, we can continue to the next slide. Okay, prone positioning. So I don't know, Are has some more experience than me on this, but
so I will talk about the patient I saw, and I'm so happy. Although I can't share images, but I saw him coming back in our setting. So it was a COVID patient in his 30s years, and he spent more than 3 weeks in our setting. So at sometimes we're not able to ventilate him, almost impossible. So we were putting him in prone position, trying to paralyze, doing whatever were possible. Prone position was giving good results, and his CO2s used to be around the 80s, 90s. And remember, we're saying that normal values should be about 35 to 45. So we should try to, to get this prone position done is really consuming about the personnel, care, and everything, but it gives good ventilation, as now the main organs are no longer pushing on the main chest organ are no longer pushing on the lungs. But it's really difficult. It asks to get great people around, people who knows how to take care of patients who are on respiratory support. So and he came out. So it was a great thing, a great achievement, because we've been trying everything, but at the end we've been saved by this position, the prone one.
So very good. So as you can see, the criteria they used for this study, they included people who had severe ARDS, which was defined as FiO2 leading to a PaO2 to FiO2 ratio between 150, below 150. That was the cutting point they used, and they were using a PIP of 5. So that was the criteria they used. So people with severe ARDS, that was the criteria. I don't know if Are and King Faisal, you are just considering people with severe ARDS to do prone position.
I've seen that we do this as almost in the last option, as some of the last options. We don't, we try everything. Of course, those patients, many times they are even less than 150. The PaF2 ratio is many times below 100. So all those criteria are good, but we try to use it as the last option because we don't have these facilities of getting many people around the patient, because once you put someone in this position, it will be really consuming either in personnel, in care, or and to ask a full a full someone to take care of this patient 24 out of 24. So it's not an easy one to do.
Very good.
Eugene, I have some comment about proning. You've concentrated in King Faisal, and I thank RF for the comment he mentioned and the good examples, especially in COVID patient. But I want to comment a little bit to our colleagues who are not working in ICU. Just for those who are working like in a referral hospital where they are doing neurosurgery cases, especially for posterior tumor surgery resection. The prone position recently in our setting in Rwanda for the patient who are having severe desaturation, who are desaturating despite the maximum FiO2 to set FiO2 at maximum 100%, you set a high PEEP, and the patient is keeping desaturating, and you ask yourself, what is the next? And then you prone the patient. We recently do it here at Sashibe also with Prof. Eugene, and the patient has the oxygen saturation has been improved. This is like a tangible experience we saw recently. So really the prone position is very helpful, especially in severe hypoxemic patient. But remember, as I mentioned, putting a patient on prone position, there are pro and cons. The cons is like, it requires enough staff. In the other setting, they have the bed where they can push the button, and then they put the patient with the bed on prone position. But here it requires the team to take the patient manually, not like using a bed as automatic. Remember also the tube, the ETT. When a patient is on prone, it can be easily dislodged. There are some challenge with prone position, but when we are comparing the advantage, in our setting, the advantage is much better.
Thank you for the addition, Jean-Paul. So we can watch a quick video, and then we will conclude after the video. We'll have like 5 minutes group discussion for takeaways, and then we will conclude.
Proning an ARDS patient receiving invasive mechanical ventilation in the ICU must be done carefully to ensure safety during the procedure. For the procedure to be successful, it is vital to use trained and experienced staff. The video you are about to watch shows the technique used to achieve the prone position and the return to the supine position. The procedure usually requires 3 to 4 people. One person remains at the head of the bed to secure the endotracheal tube and the ventilator lines. This person coordinates the procedure. The other people position themselves on each side of the bed. The procedure is performed following 5 steps. The first step is to prepare the procedure. At this stage, you have to decide which direction to turn the patient, to the left or to the right. Priority is given to whichever side the central venous lines are located. Check the length of the vascular lines and the transcutaneous saturation cable to be sure they are long enough. Move the ventilator as close to the patient as possible. Check the patient's hemodynamic status and the level of sedation. Secure the endotracheal tube and the gastric tube. Protect the skin on the forehead, knees, iliac crests, and thorax from pressure sores using adhesive pads. Protect the patient's eyes and get the electrocardiogram electrodes ready for use. The second step is to move the patient horizontally. Then they are moved towards the opposite side. From the side they will subsequently be turned towards laterally by pulling the bedsheet. The patient should be moved towards the side of the central venous line. After moving the patient sideways, the hand on whichever side they will be rotated onto is placed under the buttock. A new bedsheet is also prepared along the length of the bed. The third step is a side lie. The patient is rotated laterally in a full side lying position. The patient is maintained in this position for a short time while one person removes the electrodes from the anterior thorax and another person attaches the new electrodes to the back. The fourth step is complete proning. The new bedsheet is used to pull the patient and to move them into the final complete prone position. The body is placed in a horizontal position at 180 degrees. The abdomen is usually not supported. The upper limbs are placed alongside the body. The fifth step is post-proning installation. The patient is moved to the center of the bed. The head is turned laterally and moved every 2 hours. The endotracheal tube must be easily accessible. Care should be taken to close the eyelids tightly and avoid ear kinking. To move the patient from the prone to the supine position, the steps are as follows. The first step is to move the patient horizontally towards the center of the bed. The second step is a side lying on the same side as in step 3 of the proning procedure. The patient is maintained in this position for a short time while one person removes the electrodes from the posterior thorax and another person attaches the new electrodes to the torso. A new bedsheet is also prepared along the length of the bed. The third step is a complete supine positioning. The new bedsheet is used to pull the patient and to move them into the final complete supine position. To summarize the key points of the procedure: trained and experienced staff, 3 to 4 people, good preparation of the procedure, horizontal move, side-lying position, complete proning, and post-proning installation.
Yeah, we don't have a lot to discuss about pulmonary vasodilators because they are not available in most of our centers, and there is no good evidence on patient mortality outcomes, even if they improve oxygenation. So we can just conclude about our patient. So you remember our patient who was in ICU. So he spent 10 days in ICU, and he was placed on mechanical ventilation and dexamethasone. He received neuromuscular blockers and underwent intermittent prone position according to protocol for 5 days. He was also placed on inhaled prostacyclin, so his fluid balance was kept negative, so it's low fluid balance, and using intermittent diuretic medications. On day 8, his oxygenation began to improve, his FiO2 and PEEP requirement decreased, and he remained hemodynamically stable. On day 10, you are now considering sedation, weaning, and further weaning of the medical ventilator, and mechanical ventilator, and soon a spontaneous breathing trial in hope of extubation. So the patient is improving. Maybe Alana can help us to divide us in 3 groups, and we'll spend just 5 minutes to have like 1, 2, 3 take-home point, and then we'll conclude with that. Thank you. So Ale will have 1 group, and Jean-Paul, and I will have another group. So thank you very much, Ale. So I think they are great takeaways. So we can go back to the main threads, and we will see if we achieved all our objectives. And after that, Alana will tell us the next plan. So our objectives were to define respiratory failure, to list 4 types of respiratory failure, define hypoxemia using pulse oximetry and ABG, listing the Berlin criteria for ARDS, discuss the Kigali modification for ARDS diagnosis, describe mild, moderate, and severe ARDS, discuss about the pathophysiology for ARDS, discuss the lung protective ventilation for ARDS, discuss the parameters for mechanical ventilation for adjusting oxygenation. I don't think we went in detail for this. And understanding the parameters to adjust for CO2 elimination. These were beyond for the discussion because of our experience. So to apply appropriate interventions known to improve oxygenation in ARDS, yeah, we did this with proning, things like that, and apply appropriate intervention known to improve outcomes in ARDS patients. So yeah, maybe we can finish with this quote. If you want to lift yourself up, lift up someone else, from Booker T. Washington. So I think everyone can share the knowledge we are getting from these courses with our colleagues back in our working environment. So Alana can tell us the next plan for the next session. And if there is any comment from Ale, Jean-Paul, you are welcome to make those comments. Otherwise, I wish you a great weekend. Alana, please.
Great. Thank you, Dr. Eugene. Just to wrap up, as always, we recommend that you visit the Learning Resource Center. That is where you can find today's presentation and all of the supplementary materials. I'll share a link in the chat in just a moment. And the second link that I'll be sharing is a link to receive your certificate of attendance. When you click on the link, you'll just have to enter your name as you'd like it to appear on the certificate, and it will be emailed to you. So thank you so much for joining today. Thank you, Dr. Eugene. Thank you, all of our panelists. And thank you to our funder at Project ECHO for making this program possible. We hope to see you at our next session. It should say session 7 on the slide, but it will take place on July 31st, and the topic will be high flow nasal cannula and non-invasive ventilation. So please save the date. And if you have any questions, email echo@assistinternational.org or send a message in the WhatsApp group. Thank you.
Thank you very much. Are there any additions, Jean-Paul?
Just to thank you, no special addition.
Okay, everyone have a great weekend. We'll see you next month, okay? Thank you very much.
Thank you for participating today.
Thank you.